Yeah.
So, a very good afternoon to all of you. So, I'll be speaking on long-term assessment of posterior capsule IOL optic adherence and its impact on NDR capsulotomy rate after implantation of a hydrophobic acrylic IOL with ozone surface modification. No financial disclosures. So, intraocular lens surface modification, various techniques have been described, such as surface coating, covalent grafting, plasma treatment, and photochemical immobilization. The purpose is to enhance the biocompatibility of the intraocular lenses and lead to a decrease in the incidence of posterior capsular opacification. So, an aspheric hydrophobic acrylic IOL with posterior surface modification, UV and ozone treatment is based on the mechanism of increased adhesion of fibronectin and lens epithelial cells to the posterior IOL surface, which in turn will promote the IOL adhesion to the posterior lens capsule and help prevent PCO. So, the purpose of our study was to assess the PC-IOL optic adherence in a surface modified IOL and its impact on NDR capsulotomy rate and visual quality. It was a prospective interventional study of 93 eyes with immature senile cataract grade 2 to 4 conducted at Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. All cases were implanted with hydrophobic acrylic IOL with posterior surface ozone treatment after phacoemulsification. Cases with any ocular or systemic comorbidities, extremes of axial length were excluded. The primary outcome measure was a posterior capsule adhesion to the IOL optic as assessed using anterior segment optical coherence tomography and the NDR capsulotomy rate. The secondary outcome measures were visual quality as assessed using ray tracing aberrometry. Follow-up was performed on postoperative day 1 year, and 2 years. So these are the demographic details of the patient. The mean age was 59.46 plus minus 9.14 years. 93 eyes were implanted, 37 bilateral, 19 unilateral. Intraoperatively, no case had any intraoperative posterior capsular rent or vitreous loss. At 2 years, 94.6% had a corrected distance visual acuity of 20/20 or better. 100% had a corrected distance visual acuity of 20/32 or better. These are the visual representation of the two cases. On the left hand side, you can see a case with complete PC optic adhesion at 2 years and a case with initial smooth PC. So on post-operative day 1, there was 497 microns of fluid between the IOL optic and the PC. At 1 year, it increased to 80 microns, and at 2 years, complete PC to IOL optic adhesion was observed. In the second case, as seen on the right hand side, on postoperative day 1, there was a wavy configuration of the posterior capsule and 255 microns fluid can be observed. At 1 year, it reduced to 137 microns. At 2 years, the fluid still persisted. 96 microns height of fluid can be observed on anterior segment optical coherence tomography in the visual axis. So on post-operative day 1, 2.9% of our cases had a complete PC optic adhesion. The figure increased to 67.6% at 1 year and 73.5% cases at 2 years. Of note, more than 25% cases at 2 years still had persistent PC optic in adhesion. So this is in contrast to a study by Zhu et al., the only other study I could find with which has evaluated the PC optic adhesion in the visual axis, which evaluated PC optic adhesion in visual axis after phacoemulsification, and they saw that 41.5% cases had PC optic in adhesion on postoperative day 1. 59% had complete adhesion and 7.1% had PC optic in adhesion at 2 months. So at 2 months, nearly 93% of their cases had complete PC optic adhesion. So the contrast may be because they used sheen plug imaging, which is less sensitive than anterior segment optical coherence tomography and may have underestimated the PC optic in adhesion rate. Visual quality at 2 years. So why is all this important? The residual PC optic adhesion positively correlated with the total higher order aberration with a Pearson correlation coefficient of 0.4 and a p-value of 0.03. Sterile ratio, modulation transfer function, and root mean square total aberrations were significantly better in cases with complete PC optic adhesion. Posterior capsular opacification did develop in 7.5% of our cases at 2 years. So this is a case on the left hand side of a peripheral PCO with a clear visual axis in a case at 2 years. No PCO was seen in 92.5% of our cases. So coming to the NDR capsulotomy rates, of the 7.5% cases that developed a PCO, 85.7% had persistent PC optic non-adhesion. NDR capsulotomy was needed in 3.2% of cases. All cases requiring laser capsulotomy had persistent PC optic non-adhesion. So NDR was required only in cases that had a persistent PC optic non-adhesion. So to conclude, complete PC optic adhesion is associated with superior visual quality, less posterior capsular opacification, and known ND-YAG laser capsulotomy. Surface modified IOLs are expected to have a higher rates of PC optic adhesion with less PCO. What we saw was that nearly two-thirds of cases at 1 year and three-fourths of cases at 2 years have complete PC optic adhesion. This is the first study to characterize PC optic adhesion using high definition ASOCT in a surface modified hydrophobic acrylic IOL to correlate it with visual quality to study the impact of the adhesion on NDR capsulotomy rates, and it has a long term follow up of 2 years, which for cataract is quite a significant follow. Thank you for a patient hearing.
Very nice talk. We allowed one question, so I'll club two questions in one. So one question is, how did you quantify this PCO? Did you follow any score? And two, did you do any anterior capsule polishing during the surgery? Anything was done on any side or not done anything?
So anterior capsular polishing, we did not do. We are not doing in our cases since quite some time. And regarding posterior capsule opacification, we did not quantify it, grade it. Those involving visual axis and not involving visual axis, that was the quantification we used.
I just wanted.
Thank you.